we have Dr. S. Gomti Ma'am, Professor and Head, Department of Nephrology, Government TD Medical College, LFP, Kerala, as Chairperson, and Dr. Tukaram Jamali, Professor and Head, Department of Nephrology, KEM, Mumbai. For this session, I like to invite Dr. N. Gopal Krishnan Sir, Professor and Head, Department of Nephrology, Madras Medical College.
Good afternoon, respected chairpersons, the organizers, friends. The topic for today's discussion is infection screening, the pre-transplant setting in Indian scenario, what to be watchful for. It's a very complex topic and it's rather a dynamic one. You all will agree with me that the profile of infections which we do come across, or at least I've been going through for the past 3 decades, watching for the past 3 decades, it's quite dynamic. There are some new emerging infections. There are some infections which are just remaining with the same severity and magnitude. And there are some infections which have just gone by. So it is a kind of a dynamic process. And again, screening refers to screening of the recipients and screening of the donors. And again, there can be subtle differences and variations when you talk about screening of the diseased donors versus screening of live donors. Right. So what is the purpose of the pre-transplant screening? These are the 3 primary goals of screening program. One is to identify certain infections in donors and recipients. If you identify these infections, which will just preclude transplantation. The second one is to identify and treat active infection prior to transplantation. You all know, after institution of very powerful induction immunosuppression and very high dose immunosuppression, in the first few months, there will be a terrific flare-up of these infections. So naturally, active infection has to be identified and treated. And in certain situations, to define the magnitude of the infection risk post-transplant, and to develop strategies on preventive measures. So these are the primary goals. I'll just touch upon certain infections. It's not going to be a complete list of infections which are described in textbooks. I thought I'll just pick up certain infections which are relevant to Indian scenario. The first and foremost is tuberculosis, the most difficult one. We all know very high incidence and prevalence of tuberculosis in end-stage kidney failure patients. The exact magnitude we don't know because there are no data in most of our centers. In the reported literature, starting from 10% up to 20% in ESKD patients. And the diagnosis is not very straightforward. In most of the situations, there are atypical presentations are common, extrapulmonary infections are common. So always we need to have a high index of suspicion. In our unit, we always try to rule out hidden tuberculosis in prolonged fever and inexplicable weight loss and refractory anemia and so on and so forth. And particularly when there is a presence of ascites, it's very difficult to confirm or rule out the Cox etiology in that. The same thing happens in pleural effusion. Recently, the role of adenosine deaminase is not very kind of encouraged, even though we do it. And more of gene expert we resort to whenever we suspect tuberculosis with various biological specimens. In many centers, including ours, we do go ahead doing CT chest prior to transplant, even if the X-ray chest is normal in recipients, because there are any number of instances we have picked up the infiltrates in the CT chest, which is not revealed in X-ray chest. So this is about active infection, but the more important is the latent tuberculosis infection. What is this LTBI all about? It is a WHO definition. LTBI is a state of persistent immune response to stimulation by Mycobacterium tuberculosis antigens, but no evidence of clinically manifested active TB disease. This is LTBI. You'll be surprised to know about the magnitude of LTBI world over. It is 1.7 billion people are with LTBI. And the worrying fact is that based on many statistical modelings, it is one of the papers from Global Burden of Disease Collaboration. up to 10% of LTBI can proceed to develop active tuberculosis disease some point during their lifetime. This is about general population. But we all know the transplant recipients with LTBI are at a high risk for active tuberculosis. So here comes the importance for screening for LTBI. So how to do that? So screening for active disease as well as latent tuberculosis infection. This is a big list starting from history and to put it in one word, we need to have a high index of suspicion. That's what I would like to, because most of the instances, the picture is not very clear. And the recommendation by WHO for screening for LTBI, the 3 tests. One is the tuberculin test and the IGRA. And again in the IGRA, either T-spot TB or quantiferon. So this is a pictorial representation on the right side. So this is a kind of what will happen if there is tuberculosis, either clinically manifested and treated partially or completely, or LTBI in either the recipient or the donor. What will happen in different combinations? The panel A, it is donor and recipient, no tuberculosis infection. The entire post-transplant period may just go on smoothly without any complication. The same thing, if you switch down to panel D, the same combination of no tuberculosis in the donor or recipient, either active or latent, pre-transplant, some unfortunate recipients can go on to develop a de novo infection months or years after transplantation because of immunosuppression. The interesting fact is to note is that the panel B and C, where either the donor or the recipient have had a latent tuberculosis. After a few months, after a period of lull, both in these panels, the recipients are at a high risk of developing infection. The point of concern here is that the donor-derived tuberculosis can happen. As per one paper in a review of 511 patients, 4% of the post-transplant tuberculosis was donor-derived. Fine. Having said all that, in the Indian scenario, what are the challenges which we do have? Because most of these guidelines are all from the Western countries. In the Indian scenario, BCG vaccinations, it's an integral component of the primary immunization in India. So the BCG vaccination per se can interfere with tuberculin skin test. So it doesn't take us anywhere, the positivity doesn't mean that there is active infection. I'm talking about the general population. I'm talking about the donors particularly. So in such situations, IGRA is preferred. But are there robust data in India which has validated the utility of IGRA in the general population, that is the donors? No. And again, according to some experts, the sensitivity and specificity is not that robust in Indian population. So the consensus of the recently held, last year, a couple of years ago, there was a consensus of the experts in transplant in India for writing up a paper in transplantation. It was the initiative of Dr. Shyam Bansal with the able guidance of Camille Cotton. So the screening has to be done for those donors with a history of contact with active TB or inadequately treated TB. Of course, if caste is not a factor, please go ahead doing the IGRA, but at least don't miss out doing in the category of the donors whom I mentioned. Next, screening of the recipients for LTBI. It's very important, but in a survey, most centers in India, in asymptomatic patients with a normal chest X-ray, it is not being done, even though it is highly recommended in most of the Western guidelines. The problems are, even if you decide to go ahead to screen the recipients for LTBI, which test to do? We all know the TST, the tuberculin skin test. The problem is that the energy, because of renal failure, there is all the components of immune system are at low ebb. So a false negative tuberculin test is pretty high incidence of false negativity here. And again, low sensitivity and specificity in predicting post-transplant tuberculosis. And it applies for IGRA as well. So ultimately, the final consensus is that the screening has to be done in patients with history of tuberculosis in the past, or incomplete treated tuberculosis, or history of close contact with tuberculosis patients. So the expert opinion in India is that IGRA is superior to TST. There are some studies which have compared the correlation between the TST and the IGRA. The concordance is not more than 70%. The positivity of both these things among the ESRD patients on dialysis. So even though the problem of tuberculosis in India is pretty very high, of huge magnitude, actually we are clueless. So this is high time that all the major Indian centers, at least to start with, we should join hands and we have to do something to question this, to answer this question. A simple research design to start with, just do TST for all the patients and IGRA simultaneously for all the patients on dialysis to identify what is the concordance of positivity between the two. That is number one. And number two, those who test positive in IGRA, follow them up post-transplant. How many of them who tested positive for IGRA actually develop tuberculosis? At least 5 years follow-up or something like that. And then the third question is that a randomized controlled trial of positivity of IGRA, go ahead giving chemoprophylaxis and see what happens. This is my humble suggestion. So this again is WHO guidelines. What do we do if LTBI is detected? 3 options: isoniazid monotherapy for 6 months in adults, both for adults and children, and isoniazid plus rifampicin for 3 months. Sorry, the number is missed out there. For children less than 15 years. And the third option is rifampicin isoniazid weekly for 3 months, both for adults and children. Again, there are a lot of controversies. I happened to attend a meeting of experts on tuberculosis. There are vehement arguments for and against for each of these things, because India is facing the problem of isoniazid resistance. If you go ahead giving isoniazid as a monotherapy, you are doing harm. That is the argument against it. As I've already said, what is required is a kind of an RCT on a large scale RCT. So I'll be very happy, our center will be happy to either initiate or join this kind of a proposal. I'm just utilizing this platform to announce that. Moving on to hepatitis C virus. It is mandatory to screen all the donors and recipients for hepatitis C virus, we all know. And for the living donor, particularly the kidney donors, it is enough if you do a HCV antibody, ELISA, nucleic acid testing only if ELISA is positive. Again, I will touch upon a controversial area. If ELISA is positive, you are doing a nucleic acid test. If nucleic acid test is negative, what do you do? Will you discard the donor? Will you defer that donor? That's a big question. But the suggestion is that this ELISA positivity may just imply a past infection. So do a NAT if it is negative and wait for some time and redo ELISA positivity. In some patients, it may disappear. Even if it is ELISA positivity, if persistently, if NAT is nucleic acid test is negative, donor can be accepted. But it is a kind of controversial area. I need the opinion of the audience as well on this. In disease donor, kidney disease donor, ideally nucleic acid testing has to be done because the donor may be in the window period. So your ELISA may be negative in that period. This is a suggestion, but in the real time, in the real scenario, Indian centers will not be able to do this. Whereas all liver donors, nucleic acid testing is mandatory. And of course, all the recipients should undergo antibody testing and nucleic acid testing. We all do that. How about hepatitis B virus? All the donors and recipients should be screened for hepatitis B. How do we do that? Hepatitis B surface antigen and hepatitis B core antibody. And for the donors, hepatitis B surface antigen positivity, if there is a positive hepatitis B surface antigen, differ the donor. If the donor is negative for HBsAg, but positive for hepatitis B core IgM, the donor is in window period, again you have to defer donation. The third scenario, HBsAg is negative, but hepatitis B core IgG antibody positive, go ahead doing a quantitative PCR. If PCR is negative, can be donated, the organ can be donated to vaccinated recipients with anti-HBs titers, more than 100 units, 100 international per month. So this is the current suggestion. Fine, dengue. 10 years ago, if this topic is given to me, had it been given to me, I would not have talked about dengue at all. The resurgence of dengue for the past 1 to 1.5 decades, as an undergraduate, even a postgraduate in 1991, I finished my MD, hardly ever we have seen a dengue in Madurai. But now, every year, September, October, till December, even Jan, there is a very high dengue problem, Interestingly, during the COVID crisis, the dengue, it was very subdued, very, very interesting epidemiological change during the 3 years. But this year, again, we had a lot of dengue. And now, dengue is it's not just seasonal. All through, dengue prevalence is there, but during these months, there is a huge number. And the worrisome fact is that dengue can be transmitted through the graft. So the donor screening is preferable during periods of high disease activity in the region where it is endemic, particularly in the region where it is endemic, you have to go for NS1 testing. If the recipient is having fever, you run all the tests, and there are some, again, to quote one more infection, again, scrub typhus. And scrub typhus, during my undergraduation, postgraduate, I've never seen. After I became a professor in 2011 only, I saw the first scrub typhus fever. Now scrub has become a kind of an integral component of any acute febrile illness, so much of scrub typhus. So you need to run through the whole lot of tests, including dengue for the recipients. And evaluation should include screening for dengue. And how do we do that? Ideally, PCR in the first week, IgM in the second week. But PCR and all is not possible in dengue scenario, most of our centers. What do we do with the donors with the dengue positivity? Ideally, the donation should not happen for at least a month. And again, the diseased donors with the history of dengue within 30 days, please don't accept the donor because, there is a high possibility of the dengue being transmitted through the graft. So I'll just quote 2 published experience on dengue infection immediately after kidney transplantation. This paper is again from Shyam Bansal, Delhi. So this is a single center study in 2021, just 3 months, August to October. 23 kidney transplant recipients had dengue. Out of them, 4 had dengue in the immediate post-transplant kidney transplant, who remained asymptomatic and not treated pre-transplant. Okay, so 4 of them developed dengue. Probably the author says that these recipients were in the incubation period at the time of transplantation. So what are the consequences of it? There is a transient dysfunction, at least 2 of them. There's a requirement for platelet transfusion in 1, ICU stay in 1 patient, and the duration of hospitalization increased from median of 8 days to 15 days. And how did they diagnose dengue in these patients? Both IgG and IgM antibodies were negative, but only NS1 antigen positive. So implying that it was just the infection happened just that time. But the author's suggestion is that the recipients might have been in the window period, just acquired that infection, the incubation period, transplant happened. So they don't surmise anything on the donor source of dengue. Interestingly, this is a contrasting next paper published in KIR. I happen to review this paper. So look at this, the depiction of 4 patients, kidney transplant recipients who developed dengue in the post-transplant, immediate post-transplant period. The R11, R12, they received the kidneys from the same donor. are 2-1 and 2-2 received kidney from the second donor. These authors proved the source of dengue in these recipients are from the donors. By doing the genomic analysis, they proved that. And they also proposed the hypothesis that kidney can be a reservoir for dengue. And how did they prove that? In each graph, actually, there is a colored shaded area that shows for that period, there was persistent viruria, dengue virus, in these recipients. So it's very interesting. So in an endemic area like India, I think we need to go ahead for screening for dengue in both the donor and recipient. Fine. Strongyloides tuberculosis. Again, this is termed as a kind of a emerging infection in the transplant scenario. There's a wide range of clinical presentations, starting from chronic asymptomatic infection to mildly symptomatic diarrhea or chronic diarrhea. But the two phenotypes, clinical phenotypes, which are really worrisome are hyperinfection syndrome and disseminated strongyloides tuberculosis. Even it can lead on to mortality of up to 50% in hyperinfection syndrome, 70% in disseminated disease. In hyperinfection syndrome, patients can go on to develop hemoptysis and respiratory distress and severe GI bleed and death and so on. And the interesting fact is that the donor-derived strongyloids infection in solid organ transplant recipients is possible, even though that is not the primary cause or pathomechanism of strongyloids. Usually the most common cause is kind of a reactivation of the chronically asymptomatically present strongyloids post-transplant of the recipient source only, but it can be donor-derived as well. And if it is donor-derived, it's unfavorable outcome. So screening of both recipients and donors is ideal, particularly donors with epidemiological risk. India comes under that only. Southeast Asia, Central America, Pakistan, Bangladesh, and so on. Stool examination is very simple, that has to be done, but the sensitivity is only 15 to 30%. Better to go for ELISA, IgG. Sensitivity is up to 90%. And ideally, you have to treat both the recipients and donors pre-transplant itself. But it does not preclude transplant. It does not make you postpone transplant and all. You start the treatment once you pick up the infection at the earliest. Ivermectin is the drug of choice. Alternate is albendazole. HIV, nothing new about it, and we all know it is mandatory that it has to be, so both the donor and recipient has to be screened, and the transmission can happen through the allograft. High-risk donor, nucleic acid testing has to be done. Otherwise, for the donor, it's only ELISA. But high-risk donors, please go ahead doing NAT. CMV, we had a wonderful lecture from Professor Jasti Jan, and nothing more to add. It's more of strategizing your the surveillance mechanisms and the prophylaxis post-transplant. We all know D plus R minus, highest risk for post-transplant CMV disease. COVID, again, we had a terrific experience with COVID. COVID in the post-transplant setting, one of the highest, very high mortality, particularly the Delta wave. So with each wave and in between the periods of lull, the guidelines kept on changing. So ideally, if you have a clinical suspicion, particularly acute febrile illness, either the recipient and donor, please include screening for COVID. Otherwise, it's very difficult. In the current scenario, it's very difficult to pass a kind of a judgment saying that it is mandatory to screen. In fact, when I took up the position as member secretary of TransTran, in the first week itself, I removed the mandatory screening for COVID because, the COVID, the WHO announced that COVID is no longer a kind of pandemic. But now, the JN1 variant has come in. I don't know whether we have to kind of revise our strategy in COVID screening. And the thing is that there are a lot of debates when COVID screening was made mandatory during the last couple of years, stating that, is COVID transmitted through the allograft kidney? But there's no solid proof for that. The only two organs through which COVID virus can spread from the donor to the recipient is lung and intestine. So probably, even if somebody has had a recent COVID infection, don't deny that person as a donor, but I'm talking about the deceased donor, because the precious organs are wasted. Probably lung and intestine can be deferred and other organs can be utilized. So that is the current consensus. This was the ISOT consensus statement for kidney transplant recipients and living donors with a previous diagnosis of COVID-19, that is a treated, COVID identified, treated. They said before transplantation, there should be a complete resolution of the symptoms for at least 4 weeks, and 2 negative RT-PCR, normal CT chest 24 to 72 hours prior to transplant, and of course, multidisciplinary screening. With these screening, if you utilize the kidneys, what happens? They said the outcome was good and there was no severe COVID infection in the recipients. So it was an eye-opener kind of a thing. How about H1N1? Now again, currently, Chennai, Tamil Nadu, Chennai is facing an epidemic of H1N1. During epidemics, it's preferable to have a very low threshold to screen both donors and recipients for influenza. And again, the same thing applies for COVID, in H1N1 also. The 2 organs which can transmit the H1 influenza to the recipient is the lung and the intestine. Right? Malaria. Screening only in symptomatic febrile recipients. Universal screening of all the recipients is not warranted. Thick smear and gene sustain, the gold standard, it's commonly employed, but the real-time PCR is more sensitive. And if you diagnose, if you pick up malaria, the donors and the prospective recipients should be deferred going ahead with the transplantation, either donation or receipt of the organ for at least 3 months after treatment of malaria. Toxoplasmosis, particularly for the heart and lung transplantation, the test that is employed is Toxoplasma IgG antibody. Donor seropositivity is not a contraindication for donation, but post-transplant prophylaxis in case of donor positivity, D plus R minus, has to be given with cotrimoxazole. This does not apply for kidney transplant. Epstein-Barr virus, again, the D plus R minus, highest risk for PTLD. It does not preclude transplant, but only thing, you have to be more vigilant with a regular follow-up, and specific monitoring strategies have to be adopted for PTLD particularly. Rabies, why I talk about that is that now we are doing more and more of diseased organ transplantation. From September 2023 till currently, there is one diseased donation every 48 hours in Tamil Nadu. So last year, we touched about 178 donors with 1,000 organs in one calendar year across the state of Tamil Nadu. And this year, our aim is that, I shouldn't say that aim, it is the goal or whatever it is, at least one donation every 24 hours, if not at least one donation every 36 hours. That's what is going to happen. Today it's 19th Jan. Already 14 donations have taken place in Tamil Nadu. There is a kind of a resurgence in the program across the state of Tamil Nadu by different initiatives and measures by the bureaucracy and the political dispensation and the technocrats. Very good acceptance rate among the public. Yesterday, a 20-year-old young person died, and the moment the family got to know, the family started pleading for taking up the organs. That's it. So we have to think about the different problems and scenarios. A diseased donor with encephalitis of unknown cause, better don't take the diseased donor. Because many instances, the history of animal bite may not be forthcoming. And once rabies comes, it is 100% mortality. And one of the questions was raised in one of the discussions. This is a major problem in the diseased donation setup, where how to identify acute infection or active infection in the donor. Because, you can have leukocytosis. Just leukocytosis doesn't mean it is infection in the diseased donor. There are many other causes for leukocytosis. There can be other causes for thrombocytopenia, other causes for elevation of transaminases, ischemia of the liver, and so on. And it's very difficult to get the cultures immediately. So what to do? What we do in Madras Medical College, at least we rely on serum procalcitonin and a simple measure like looking up the toxic granules and neutrophils. And I don't know whether these are validated and so on. It is a very tricky issue in these situations. Also, there is a suggestion that ideally the perfusate of the allograft has to be cultured, and many a times, even including fungus, there can be source for this. Dr. Anila has come out with a paper of analysis of the graft nephrectomies after disease donor transplant. The most common cause is infection. So with this, I just, sorry I exceeded the time limit. Thank you so much.
Thank you, sir, for the very informative and practically relevant discussion and sharing your vast experience in this realm. I have a query actually. We had a patient on evaluation pre-transplant. She had subcentric small lymph nodes in the CT chest. So she was proceeded with bronchoscopy, but the procedure was deferred because lymph nodes are very small. But we proceeded with transplant, but 4th week transplant, she developed a florid tuberculosis. So what is your take on this? What should have been done to prevent this?
It's very difficult to answer. That's what tuberculosis is posing such a big challenge. Maybe I would have the living-related donor transplant, right? Maybe we could have postponed performing transplant for at least a month or two. That's what I might take. It's very difficult to think. Just postponing transplant, allowing the patient to be on dialysis, particularly the patient is not doing well on dialysis, is a tricky issue. Suppose the patient is doing exceedingly well on the dialysis, I would have preferred to wait for a couple of months and observe.
Thank you, sir. As we are short of the time, we will take only one question, sir. If dengue screening is positive in either donor or recipient, what proportion develop symptomatic dengue, as the treatment is only watchful waiting?
Yeah, if there is positivity in dengue, I would not go ahead with the transplant based on the available literature. I cannot be very categorical. At least for a month we have to wait, because the literature that quoted both the Delhi paper and the other paper from France, Reunion Island, none of them, there was no mortality in them. But in the France paper, they had 2 more patients discussed. I omitted that. One of them developed a dengue shock syndrome post-transplant. So the outcome is very tricky. So it's better to wait for at least a month after the dengue resolution, either in the donor and recipient.
Thank you, Chairperson. Thank you, sir, for this, for the addressing practical day-to-day question we faces.